Yes, good evening once again, and good morning to Professor Helen. So I'd like to welcome you all to our today's DCR session, which the talk for today is about how to align our research questions to the study design. So our today's session is going to be facilitated by me, but in conjunction with Professor Ellen Weber. I know a few of you might have heard about her, probably you might have seen her, you know her from your colleagues, but I know majority of second year residents have not met Professor Ellen Weber. So before we begin our session, I'll just like Professor Ellen to introduce herself so that the second year residents will start knowing you, because I know you're going to meet them a couple of times and several times. Prof, you're welcome.
Asante, Humphrey. Mambo, habari asubuhi for me, and oh God, I can't remember to say. Good evening to all of you. I'm Ellen Weber, or BB. I'm a professor of emergency medicine. I practice at the University of California, San Francisco. I've been to Muhimbili a number of times to help supervise clinical work, and then later help to teach and mentor research. I've done research in a number of areas, and with the help of all of you and your colleagues, I've done research in many more areas over time. I've recently stepped down as the editor-in-chief of the Emergency Medicine Journal, which I did for 12 years. So I think that kind of sums up my career, and I'll let you get on with the lecture.
Okay, thank you very much. So Prof. Ellen is famous known as Bibi. So if you hear someone saying Bibi, just know he or she's referring to Prof. Ellen Weber. So we'll definitely go straight to our talk because we have approximately 1 hour. Since Bibi in the next 1 hour she has to attend other duties. So we'll try our best to make sure that before she leaves, she at least gives a summary of all that we have been discussing. And probably if there'll be any clarifications or questions, she could even add more to our discussion. So as I said, the talk for today is aligning our research question with the study design. This is one of the most important parts in research, which we would like you to have the general concepts, which we're going to be discussing in today. So our main goals and objectives for this session, and just to declare the slides that we are using, these are slides from African Federation of Emergency Medicine, which have been prepared for to be used by different cohorts and to be used by different researchers on giving different talks. So these are all adapted from AFM with some edits and modification given the time and the changes of the science in research. So we'll definitely be using them, and hopefully you'll get to learn something after we are done with the talk for today. So our goals and objectives is to, one, describe standard study designs. Two, to understand the definition, the uses, the disadvantages of different types of study design. So just to not confuse you, in general, we're going to be talking of study designs, but within our talk, we'll be talking of different aspects in a way that we have isolated them. But in the end, all the concepts that we learn, you should have them as a single group. But as we're going to be discussing, you might be seeing us discussing things in isolation, but all sum up to the study designs. Now, what is a study design? A study design, I'll pose an example so as you can clearly understand what a study design is. We have all been working clinically, and we have had some uncertainties when we work clinically. It's either uncertainties with a certain management, uncertainties with a certain disease when a patient presents to us, uncertainties with a certain knowledge that probably we are not sure of. But as well, when we read and to acquire knowledge in our textbooks, there are things that are discussed, and sometimes we still have questions, and we might have partial answers, or we are not very sure with what is being spoken of, or you wish something could have been done more. Now, those things or those uncertainties that you have, those are things that develop into research questions. Now, once you have uncertainty, once you have a research question from the uncertainty because you wish to know something more, now for you to get to know the answer or to probably come up with an explanation to that, you need to do a research as one of the things that could answer that uncertainty. Now, the process, the approach, and the strategy that you use to answer that particular research question, that's what a study design is. So basically, it's just how am I going to collect data? How am I going to approach the population? How am I going to get my study participants in order for me to look on different things to answer my research question? So the approach and strategy that you use in answering that research question, that's a study design. That's why we always insist it's very, very important to make sure you have a well-developed research question before you select your study design, because your research question guides you to what type of study design will effectively answer your research question. And as we move along, you're going to see why is it that we have insisted that from the start of the talk. Now, the concept that we want to start with is understanding prospective versus retrospective studies. These are terms that you have heard, you have read along, you keep on hearing, and you will hear them. So it's very important to differentiate these two and to clearly understand and have the general concept about it. So when we talk of prospective, in a simple way, it's like starting from now, and then you collect data as you move or as something presents. So basically, a prospective study is where you enroll participants, you collect data as they present. Or when an event occurs at that particular time when you're doing like you started doing your research, and then moving forward, you are collecting certain things that answers your research question. So you're basically gathering data as they occur within real time, moving forward. When you talk of a retrospective study, this is something that you're going to already formed data set or a database, or sometimes even a registry where you collect information in a data that already exists. So that's something that we talk of a retrospective study. So prospective is like moving forward as something presents or as you're doing, or when an event or an outcome occurs. And retrospective, you already have data, you're going into that particular data which was already there, either it could be a registry or a data set or a database, and you're gathering information to answer a research question from that particular recorded information. There is an advantage and a disadvantage to each of these modalities or studies. Prospective, as I said, is you're gathering information as they present or when an event occurs. Basically, there are less chances, if not negative at all, missing any data because you know what you want and you're collecting as it presents or as it comes. So basically, the information that you want, you have predetermined already. And when it comes, you know this information, I need to take it. So chances of missing data within this type of study is very minimal. But disadvantage is time, more costly, uncertainty about patient numbers, need to consent. Why is it that we are saying time is basically on top of risks of dissertation? I'll start with an example of dissertation. Dissertation has tentative timelines that one has to have. So if you're doing a prospective study, it means you have to meet a certain time because in the end, you'll be required to submit. Now, if your research is a prospective and you're collecting information, but then the information that you need to collect is not sufficient, and then time has caught you up, it means when you're doing a prospective study, there's always a time component which might be a factor or a disadvantage given the timelines that you have, because any research should have a tentative timeline. Specifically talking of dissertations which have strict timelines, it's not a bad approach, but I'm just saying something that you should always have in mind. It's more costly because it requires more resources. And sometimes we say it's uncertainty about patient number because at times you have predetermined information, like probably I always see 20 patients every day that have sepsis. If I'm going to do a study collecting information about sepsis as patient comes, I'm sure within 3 months, I'm going to have all my patients. But it comes during the time you're collecting data, the numbers have gone down. So sometimes you might be certain before you begin the study, but once you begin, you find that, okay, time is running up and you're no longer having the number of patients that you expected, because prospective is you collect as they come. Most of the times, prospective studies, you will definitely engage with participants. So there's always a need to have consent. Now, talking of retrospective study, as I said, you're going to a data set, you're going to a database or recorded information. So that's the advantage, that everything is there, but whatever is in there might not be sufficient to answer your research question. But one of the advantages, whatever information is needed is somewhere recorded already. And most of the times you are dealing with records, you are dealing with files, you are dealing with electronic medical records. So you do not need consent from the participant. As you come to talk about ethical consideration, what you only need is a waiver of consent of going into participants' information, but you don't physically ask consent from the participants that you are taking the information from. The disadvantages is recorded information or stored information. You're not the one that did that information or recorded it. So probably there are high chances of missing data, which you can no longer recover them. The other thing is you might have a challenge in identifying the population. What it means, you might have you're doing a retrospective study collecting data throughout the year of 2025, 2020, 2025. So it's a lot of information that you need. Now, because you're not sure which patients or which participants will have your criteria that you want to use to answer your research question. So you might have a challenge of knowing, how do I get to narrow down these 1,000 patients that are within this database to get to know which participants I need to include in my study. That's the other disadvantage of a retrospective. The other thing is it may require interpretation, which can be prone to bias. Again, you'll definitely have your predetermined criteria, but now going into that recorded information, there are times, because it's not documented or stored the way you want it to be based on whatever data that you're collecting. So there are times you might be forced to make some interpretations in that data just to fit your criteria. Now that already brings some sort of bias in that particular data that you're collecting. So they all have advantages and disadvantages, but we always say you need to weigh, what does my research question tells me, and which among these should I use to effectively answer my research question. So there is no clear cut that use a prospective for this study, use retrospective. There is a preference, as we're going to see later, but the question that you always need to ask yourself with this research question, should I do a prospective or a retrospective? Now, the other concept we want you to learn is about the broad categories of research. So we have two main categories. We have quantitative research and qualitative research, and then we also have mixed methods. Quantitative research, from the word quantity. So it's quantity that is equivalent to numbers or numerical. So what you're basically answering a research question using numerical data. Whatever information you are collecting to answer that research question that you have is going to be a numerical data. Yes, there are different types of data, as I know you might know them. Like you can have continuous data or categorical data or variables. Whatever data you collect, in the end, you convert into a numerical format so that you basically do some analysis to have or to answer a research question. So basically, it involves the use of numerical data to answer whatever research question that you are having. With qualitative research, it's more of exploratory types of research. Basically, you don't use numerical data, but what you do in qualitative research, you'll either gather opinions, you'll gather explanations, you'll either do interviews, you'll gather observations, and the way you're gonna report it as we're gonna move forward with this year, you're gonna see we don't much talk of qualitative, but then the way you're going to report this is going to be more of an expression of what the participant said. It could be quotes that you're going to be saying, and it's a different arm of research, which definitely needs more expertise in that. But quantitative, you use numerical data. Qualitative, you don't use numerical data. Mostly is quotes that you're going to be using, themes that you're going to be using in answering your research question. But then we also have mixed method research. The mixed method is where you combine both quantitative and qualitative, meaning you collect both quantitative or numerical data, but you also collect some sort of explanations or do interviews to gather information, and then later on represents them as the qualitative data. So you can have an isolated quantitative, an isolated qualitative, or you could have a mix of both qualitative and quantitative. Now, for your dissertations, we always recommend, we're not saying you should not do or you should run away from that, but what we recommend, we don't really recommend qualitative or mixed method studies, because definitely for someone that is doing or beginning their research career, these are type of research that needs more expertise that one has to understand. So likewise for dissertation, we don't really recommend you doing a qualitative or a mixed method, but it does not mean you should not do at all, but we just don't recommend, given the timelines and the deadlines that you have, this might not be feasible type of research for you to do. Now, speaking of quantitative, quantitative is further divided into two broad categories: observational studies and experimental studies. I know when you look into different literature, or you even just Google, when you type research study designs, they'll bring these two main studies. Or sometimes they'll bring something else that we're going to discuss, but it should not confuse you. In the end, we're going to align all the concepts that we're going to learn from what we are going to be discussing. So quantitative is further divided into two: observational, experimental. So observational studies, in a simple way for you to understand, these are studies where the researcher and the research team do not do any intervention. In other words, whatever data you're collecting, whatever information you're collecting, whatever you're going to be observing to answer a research question, you as a researcher or a principal investigator or your research assistants, they are not doing any intervention to the study participants. Now, not to confuse you, but just to highlight this concept, there might be some interventions that are going on. I'll give an example. Probably you're looking at certain antibiotics being prescribed more, and they are what brings or what happens to the patient that receive this sort of antibiotics at ED. The treating physicians will be working at the discretion of the protocols at the hospital. So basically, there will be a group that they'll receive the antibiotics, there will be a group that they will not receive, but the determination of them receiving or not receiving is not for the researcher team, the research assistant, or the principal investigator. Though that's what you're going to be studying, there's some sort of intervention going on, but the researcher and the researcher team does not have control or do not intervene. I'm just bringing this concept so that it should not confuse you. Like, there might be an intervention, but it's just that you're not controlling that intervention. This is different from experimental studies. Experimental study, the researcher team, the principal investigator, and the research assistants have a role in assigning patients to specific type of groups. And specifically, you are doing an intervention to a certain group to measure the effect of that particular intervention. So experimental studies have an intervention. The intervention is determined by the researcher and the team that is doing that particular study. So a clear cut is observational. The researcher does not do any intervention. In experimental, the researcher does an intervention and in the end measures the effect of that intervention based on what research question he or she is going to be having. So quantitative is observational, experimental. Now, observational studies are further divided into descriptive studies, analytical studies. Descriptive studies, just from the word description. So these are kind of observational studies where you are mainly describing what is happening to the study population or to your study participants. So there are some sort of research questions that whenever you have it, you're just gonna need a descriptive observational study to answer that particular research question. And basically, it's description about either its frequency, proportions, prevalence, incidence, just describing the characteristics of what you see within your population with no any complex analysis. So that's a descriptive observational study. Now, descriptive observational studies always help us make different hypotheses. So there are things that once you're describing, they give you more questions which you need to answer. Now, for you to answer those questions, there is where the analytical part comes in, or the analytical studies come in, where you have analytical observational study. It's an observational study, but then you're going into deep analysis to answer certain hypotheses that they have been presented or you are having as a research question. Now, when you do an analytical study, this is where the terms association comes into play. So there are two terminologies which I'm sure you've heard about, exposure and outcome. So when you are doing an analytical observational study, there are things that you're observing within or characteristics that you're observing in your population. And you had a research question that probably this could be leading into this, or it could be associated with this. For you to say for sure, this is what I had as a research question, and I think this could be associated, you need to do an analytical observational study. Now, when you do an analytical observation study, then you end up having an association between the exposure and the outcome. So it's more than just description. With descriptions, with a descriptive observational study, you cannot make an association. You can just have an hypothesis, but you cannot conclude that this could be associated to this. With analytical observational study, then you can come into associations. So this is to further explain the descriptive studies. As I say, descriptive studies, they are more of description of whatever characteristics, whatever things that you're looking into the study population, and they do have advantages and they do have disadvantages. The main advantages that comes into mind, they are quick, they are easy, they are inexpensive. Because you do not really need to you do not need a lot of information, you don't need a lot of time to do descriptive national studies because they're mainly either a survey, you're sending just a survey to people and then they answer certain questions and you just run normal frequencies, normal proportions, and you have your answers to a certain particular research question. They are very useful for trend analysis. When you talk of trend analysis is when you're looking at change of a certain particular characteristic in the population over time. You only need to describe like, okay, within 5 years, there have been increasing number of cancer patients presenting to the ED. So this is just a description of what happens, but you cannot really say why is it that that is happening, or what is it really that associates to this increase. Now there comes a different thing, but it's very useful for trend analysis. It could be a point of where you develop an hypothesis, as I said. You see a certain sort of results from your descriptive study and you're like, okay, probably there's something more that I need. So it helps in developing different hypotheses. The disadvantage, as we said, it cannot bring in any association, but also it's prone to bias and confounding. Bias and confounding is another big concept, which in time we're going to also be learning. But just to briefly explain why this is highly prone to that, in observational studies, in observational descriptive studies, given that you're only dealing with description, there are a lot of things might be accounting for whatever you're reporting, which you have not looked at. And this brings in the confounding, and sometimes you might even be biased given the information that you have just collected. So these are studies that are highly prone to bias and confounding, which in the end, you might need to have a lot of explanations trying to explain exactly if your results or your answers to your research question are really true and not just by chance. And then the observational analytical studies. As I said, these are studies where you go into associations between certain characteristics within the population. Just to make it clear, I'll give an example. How is it that we are saying this goes into association? So the first example is where you have patients with COVID-19 and they end up dying. In a description, you could just have said males who presented with COVID-19 had a higher proportion of dying. That's just an example that I'm giving. Or females that came in with COVID-19 had a higher proportion of dying. But then that's just describing what is happening to the population. If you now want to associate gender, because there's a component of gender that you will see. In description, it just tell you gender. When you look at gender, proportion between male and female COVID-19, and you look at mortality, there is a difference. It will tell you description. But now you're like, okay, it seems the gender could be associated with mortality in patients with COVID. Now, for you to do that, you need to do an analytical observational study. And this comes from your research question. The way you frame your research question, or the way you have aligned the research question, it will tell you what things you need to do later on. So I'm giving this example just to know why I'm saying this is descriptive, this is analytical. The other example that I could give is DK. Okay, you have DK patient presenting to the ED, and some die, some survive. And one of the things that happen in DK patient, they could have hyperkalemia, or they could have a normal potassium level. In description, you could just say majority of patients that had DKA, majority of patients with DKA that ended up surviving maybe had a normal potassium. You're just concluding that as a description. Now you want to see, okay, is electrolyte imbalance, specifically potassium, in patients with DKA associated with mortality? For you to do that, then you go into the next kind of observational study, which is an analytical study, because there are certain analysis that you need to do for you to say that this electrolyte imbalance is associated with mortality among patients that presents with DKA. So that's the difference between descriptive and analytical observational studies. And I've been saying association, association, association. I know probably when you have been reading, you might have come into term causal effect. Now, causal effect is another terminology. Sometimes people use it interchangeably with association, but those are two different. They're not the same, and they are used at different scenarios. I do not want to confuse right now. Remember, when you're talking of observational analytical, we talk of associations and not causal effect, because causal effect is something different that comes with a different type of study. Because I know what majority will sometimes use these things interchangeably. Okay, so just to summarize, I know I might have already confused with all that I've said. So the first thing that we discussed today was prospective studies versus retrospective. The next concept that we learned was quantitative research, qualitative research, or a mixed type of research. Now from there, we build on the quantitative research. Quantitative, we said it could be observational or it could be experimental. Experimental, we're talking of interventions. Observation, we're talking of no intervention. And then observational, we further went down. In observational, it could be descriptive, it could be analytical. And we discussed what we mean by descriptive, we discussed what we mean by analytical. Now, all this that we've been discussing, whatever research question you're going to be developing, you'll always know, like, okay, with this research question, a certain particular study design, when I use it, it's going to answer this particular research question. Because if you don't do that, you might end up with results which are not valid, or you cannot justify the results as to why these are the results given the study design that we used. So we're done with the observational studies. We now go to experimental studies. So experimental studies are another aspect which is not commonly done as dissertations, but it's always good to know. And again, we don't prohibit doing experimental studies or interventional studies, but we are always cautious given the time limit that we always have with dissertations during a residency. But experimental studies, What it means, as I said, you have a researcher or a principal investigator with the research team assigning participants to groups, putting in an intervention based on the research question that they had, and then measuring the effect of that intervention as an outcome. So you always have a predetermined population of interest. You already have an intervention of interest. It could be one, it could be two. And you already have an effect that you want, or something that you need to measure as an outcome from this particular intervention. That's what an experimental study is. And experimental studies does not mean, because I know mostly that probably you have been seeing is all about drug, or trials. No, sometimes an intervention, it could be a certain training. An intervention, it could be a certain sort of skills that one is given. An intervention, it could be something added to what is commonly done. So I do not want you to stick your mind when you say experimental intervention, it's all about testing drugs. No, intervention could be anything. What are the advantages of this? Now, this could establish what we call a causal effect relationship. Given that the researcher predetermines the population of interest and has the intervention, we are highly likely to associate whatever characteristics that we are looking at with the intervention that we are having. We can highly associate this, or I don't want to use the term associate because commonly the word is used is the causal effect relationship that comes in with experimental studies. And the other advantage is you can control bias because there are different methodology paths that you do in experimental that reduces the bias not to zero but to almost zero in comparison to observational studies. We have ways of reducing bias in observational. We have ways of reducing bias in experimental, but it's more easy to reduce bias in experimental studies in comparison to observational studies. And this is through randomization or allocation concealment. We'll a bit touch of randomization and allocation concealment, but I do not want to bring in new concept as we're just talking about study designs. The disadvantages of this one is very expensive and time consuming. You need a team that will do the experimental study. Less likely you'll only have one member doing an experimental study. There are chances of not doing it effectively the way it's supposed to do. Now, given that there is an intervention, there's always going to be ethical consideration, regardless of whatever intervention, even if the intervention does not bring any harm. Given that you're subjecting a certain group to a certain particular thing and the other group is not having, already definitely there are a lot of ethical considerations that should be considered. It requires a well-set, a well-prepared protocol, and any person involved in that research should be trained. In general, anybody involved in research, whether they are research assistants, principal investigator, or it's you alone, you definitely need to understand research. But with experimental, it even needs more training because if you just don't do the way it's supposed to do with whatever protocol that you have, the chances of you ending up with wrong results is very high and you'll have already used a lot of resources and time. So extensive protocols and trained personnel is another disadvantage. Sometimes the effect that you measure or the measure that you have after doing an intervention as an outcome, it might not be of clinical significance, or it does not always mean it should be taken the way it is. We have been doing journal clubs and we have gone through different experimental studies, and in the end, you'll ask, how do we adapt or we don't adapt? So sometimes it's not that everything that comes out as an outcome is taken given that it's an experimental study. No. Difficult to study rare diseases and long-term effect. So if it's rare diseases that you're looking at an outcome that is rarely occurring, this means you'll need a very long time to gather sufficient data for you to come to do the analysis to conclude about whatever intervention you are doing. So sometimes this is other disadvantage or limitation of experimental studies. So in summary, what it meant is you have a starting point, which you have a population of interest. I'm either taking all male patients with prostate CA at stage 2, or I'm taking all female patients with cancer, cervical cancer at a certain particular stage. Among them, I cannot study all. I'll definitely take a certain particular study sample. Now, you're going to do randomization, and this is the component which brings in about reducing the bias. Randomization is also in observational, which reduces the bias, but here reduces the bias in a way that you assign patient to two specific groups, which you really know, like this particular group is going to have this intervention, this particular group is not going to have intervention. So you basically have a test group and a control group, and you measure throughout time to observe whatever outcome that you wanted in relation to your research question. So I'm going back to the research question because all that we're discussing is to answer your research question that you have. And your research question is the one that determines what study design you're going to use. So in experimental studies, there are things that are preferred. One, you should always have a control group. Basically, you have two groups. One is the interventional group or the test group, and the other one is a control group. And this is done so to allow comparisons. Because you cannot say that whatever intervention done brought this benefit or brought this outcome as a result if you did not have a control group with almost the same characteristics to the intervention group. So that whatever conclusion you make, it was in comparison to a certain thing. If it's two different drugs that you're testing, you also need to have two groups so that you can have a group to compare to and then make up conclusion. The other thing is randomization. Randomization reduces bias. And randomization is always the gold standard for you having a control group. And you're doing randomization so that you avoid something that is called an allocation bias. If you don't randomize and you're like, I'll do the allocation of participants. If you're doing an experimental study and the research team wants to assign patients by themselves, there are chances of you saying, no, this patient seems to be old. If I'm going to put them in intervention, probably it might not really work. Let me put the young patients in the intervention group. But if you do randomization, you don't have control of what happens. So it reduces significantly the bias that might be in the two groups. So it's always preferred that you do randomization. The other thing is blinding. Now, blinding, we have different sort of blinding. And blinding is just concealing to the research team or to the study participants about what is happening. And you are doing this so as to avoid people changing or showing you an effect because they know what is happening to them. So for the research team, it's also important to blind because you might ask yourself, why should the researchers be blinded? Sometimes if you're testing a drug, if the researcher team know, they might end up changing certain aspects given that they know this is the intervention group, this is the control group, just to have the desired effect or to have the desired result that they want. Similarly, if the participants know that I'm in the control and I'm not receiving anything, they might change their behavior given that they know I'm in the control group, similar to the one that they are in the intervention group. So the many more factors that you bring in, meaning that the more you have, the more you include randomization, the more you include blinding. It could be blinding the research team only, blinding the participants only, or blinding the entire team with only few people that know what is happening and probably not directly involved in the research. Because if they are not blinded, there are times that they might alter what is happening to the group so as they could have a desired effect. So that's why it's very important sometimes to always ensure that there is also blinding in experimental studies. So this is what I was talking about. Randomization avoids allocation bias. So the researcher and this team does not have control of who to go into which group. And blinding is what I was saying. It prevents performance bias. Performance bias is where participants might change their behavior based on whatever groups they are, given that they know what is happening to them. And assessment bias, now this comes to the research team that is doing, either it's the statistician or it's the principal investigator. If sometimes know what is happening and see that things are not going well in the intervention and they want to prove that their intervention is doing okay, they might change some aspects so that it just brings the desired result. So it's always important to have blinding just to make sure that you don't introduce this sort of bias. The more you have do randomization, the more you have blinding, like you have both randomization and blinding, the more significant results that you're going to have, and they will not have any sort of bias. You cannot prevent bias 100%, but you can always minimize bias by doing different things when you're doing your research. The other key concept that we wanted us to discuss is diagnostic studies. Now, diagnostic studies, they are now coming up, even with, if you look on the previous dissertations, which we have shared with you, there are not many diagnostic studies that people were doing. Majority were doing the observation studies, which is also an observation study, by the way, but then they are not doing this component of diagnostic studies. But there is now an increasing trend where residents are doing diagnostic studies. So we felt like this is also an important thing that we need to discuss today when we're talking of the study designs. So what do we need to understand about diagnostic studies? So there are two things that I want you to have in mind: an index test and the reference standard. That should first click into your mind. Index test, reference standard. And the other thing that I want you to not solidify in your mind or have it as a key, have it as a solid thing that doesn't change, is diagnostic studies does not mean we only involve investigations, because that's the other thing that people have been mixing up. So diagnostic studies, we have index test, we have reference standard. And it does not mean we are only involving investigations. There are more than investigations that can be involved in diagnostic studies, as we're going to see some few examples. So with diagnostic studies, two major things that it could do. It can tell you how an index test predicts a disease. It can also be used to see how best a certain test performs compared to a reference standard. So for you to clearly understand, I'll use this example here. So the first thing that I said is a diagnostic study can help you predict a disease. So let's talk of appendicitis, which is very common and we all know. So appendicitis is one of the conditions that have well been studied, with a lot of things that are related to appendicitis have been brought into concepts. We know there are key historical features or key history things that relate to appendicitis. We have key clinical findings or tests that are related to appendicitis. We have certain blood tests or investigations that are highly related to appendicitis. We have certain point of care tests that highly related to appendicitis. We also have different scores. Now, these are things that are being studied. Someone had a research question, they employed a certain study design, and they ended up saying, okay, if a patient presents to you with abdominal pain, right lower quadrant abdominal pain, coming in with this history, with this score and this, they're highly, or they have a high chances of having appendicitis. So that was the research that was done. Now, there are times these research have been, whatever things that have been reported in relation to appendicitis, it was a study that was done and validated, probably in some other settings. It does not mean it will be the same within your setting. Though most of the times when they are trying to validate certain information or certain characteristics within the population, they always try to have all sort of standardized patients to make sure that at least it could be generalized to different settings. Now, diagnostic study, you're trying to take what is already known, but trying to see with these index tests that have been used. Now, the index test here that we're going to use is not a test. I'll say probably, let me say Alvarado score. So I'm saying, okay, Alvarado score has been used to say which patients are more likely to have appendicitis. But how does this score perform within our study population or within our patients? So I use Alvarado score as an index test. Like, this is something that I want to see how it performs. When I say how it performs, you want to see how sensitive it is, how specific it is in determining or giving me high likelihood of appendicitis within our study population or within our study area or within our ED. Because these are things that have already been studied. You're not invalidating, or you're not saying that no, this was wrong, but you're only trying to see how best does it work within this scenario or within the area that I'm working. And I'm going to tell you the importance of this, why we sometimes do this sort of studies. So you take that as an index test. So it's not a diagnostic, I mean, it's not an investigation, but you have used the score as an index test. Someone else might use, okay, I'll use point of care ultrasound as an index test. Someone else will use a certain specific examination as an index test. But again, you should always have a reference standard. We're saying have a reference standard because you can never do a diagnostic study without having a reference standard. The reference standard, again, it could be a test, it could be a score, it could be an outcome that you specify, but it should always be a confirmatory thing. Now, for this case, I've given an example, the appendicitis after surgery. So what it means, your reference is all patients, whatever patients you're going to involve within your study, that you're gonna score them with Alvarado to see how it performs in appendicitis. In the end, you're gonna see which among them had appendicitis after surgery, because that's confirmation, so that you end up calculating or doing the test performance for your Alvarado score. So then don't get confused with the test performance that I'm speaking of. This will come slowly, but what I'm trying to bring in here is just the concept of how do you use a certain investigation clinical finding as an index test in comparison to the reference standard or the gold standard. So what you need to understand, the reference standard should always be a confirmatory thing or a gold standard test. So never use a reference standard as something that is an assumption or that cannot be objectively measured. It should always be objectively measured and not subjective. Thus, you can calculate different things that arise from diagnostic studies, including the sensitivity, specificity, and the likes. The other thing is we said a diagnostic study could be used to compare between two tests. Now, the point here, we are always trying to do diagnostic studies to try see if this is the gold standard or it's the reference standard, but probably it's not available within our setting. Is there something else that could be used because it performs similar to the gold standard? So we're just saying there is a gold standard, like the example that I've given here. We all know if it's a trauma patient, CT scan is a gold standard for you to know they have an intracranial lesion or they don't have an intracranial lesions. But as we know, not all settings do have CT scans. Now, is there something that I could use which might be performing the same way as a CT scan would perform if I cannot do a CT scan? So you find an index test. Now, an index test, I've given an example, is probably using the rules. We have different CT head rules, which are clinical decision rules. So you're trying to say, well, if I take a certain clinical decision rule and compare it with a certain reference standard or gold standard, how well does this perform in our setting? So that I can confidently say, if you do not have a CT, if you use this index test or this clinical decision rule, its sensitivity in picking in that likelihood of intracranial lesions is 90% in comparison to the CT. And someone is happy, like, okay, if I use this effectively, I'm more likely going to similarly, just like what the CT would have said. So you are trying to see something that is readily available, not expensive, could be repeated several times, just to see how well it performs with the gold standard that is not available in your setting, or it could not be repeated, or it's expensive. Sometimes I've given this, but sometimes it could be two same tests. For example, you're having a bedside malaria test and you're having a blood smear. We know the blood smear is the confirmatory and the gold standard, but then you're not able to do it at all health facilities. You're trying to see, could my bedside malaria test perform equally or even better than the gold standard that I have within my setting? And again, you're not invalidating anything. You're just trying to find what best options could be used that performs the same as the gold standard in that setting that you have. That's what diagnostic studies are. And the way we report the outcomes of diagnostic studies or the results of diagnostic studies, we have things that we report which are called receiver operating characteristic curves. Again, this is another new concept, should not confuse you. We'll come to learn as we move on. We talk of sensitivity, specificity, positive and negative predictive values, likelihood ratios, both positive and negative, and we also talk of diagnostic accuracies. And this is how you're going to report the results when you do a diagnostic study. So all that I've been discussing is all about study design. So we have looked at different study designs and what they mean. And now you should always make sure you link your research question to the study design that you think is going to answer best your research question. So how do you choose a study design? Like, how should I choose a retrospective and a prospective? Or why should I choose prospective and not retrospective? Why should I go with quantitative and not qualitative? Why should I go with observation and not intervention? Or why should I choose descriptive versus analytical? So to say, a prospective, experimental, or interventional has less chance of bias. But again, as I say, we don't really recommend you doing an experimental study during your dissertation, given the timelines and the resources that are needed for an intervention. So, but a prospective interventional study is the study that is less likely to have chance or bias, meaning the results that you have, less likely they are by chance. But again, you cannot do an interventional given the time that you need, the resources that you need, and probably the team that you're gonna need to do this. But it's just a good concept to always know that. But what always guide the study design is your research question. Based on the research question that you have and the uncertainties that you want to answer, that's what's going to guide your study design on which to choose. The next thing is ethics. When we are discussing the previous concept, there's area where I said some will be determined, the study design might be determined by the ethical considerations that are within, that you need to consider when you're going to be dealing with the study participants when you're trying to answer your research question. The other thing is availability of data. Availability of data now comes in whether prospective, retrospective. The next thing is also feasibility, the time, personnel. And these are key things that you should always think. Whenever you're writing a research question, you should just think, what ethical considerations are there? What is data available? What's the feasibility? Because all this gives you the answer to what design you need to use. So, having said all that, we'll give just few clues of what things could guide to what type of study design you might want to do. So, things that might favor a retrospective design. And it's not a clear cut that when this is there, then definitely it's a retrospective, but these things that if they're present, they might be in favor of a certain type of study design. For example, if your research question is answered by data that is already existing within the records or within the database, definitely you will have to do a retrospective study. If you're talking of rare diseases that you know within 1 year, at the ED, I will only have 5 cases, don't do a prospective study because it means you will need 1 year to have 5 cases. If you're looking for 100 participants, it means you need 20 years to get those patients. So definitely, if it's a rare disease and you need several years, you definitely need to go to something that is already available so that you have a room of taking a lot of data to make sure that you counter for that particular rare disease. If you're trying to look for trends over time, because trends over time needs a quite significant amount of data to show a trend of a certain characteristics within the population. So if you're looking at trends, mostly you might want to go retrospective because you need a large amount of data to definitely justify a certain trend. Because if you're going to do it prospective, it means you might need a full year because it's very difficult. You might say, yes, in 2, 3 months, there's this trend, but then it won't really be much accurate given the short duration that you have done. So that's why most of the times, if it's a trend is involved, probably you'll want to do a retrospective. Things that could favor prospective design, if the existing data does not answer a research question, then you need to do a prospective. If you know that the way the data is recorded within the records or within the database that is there within the registry, I'll have a lot of missing information, then that favors a prospective. If you know it's going to be very difficult to identify cases from the existing data, definitely you need to do a prospective. And if you are very sure that I'm going to have a sufficient number of eligible participants within 3 months, then I'll recommend, it will favor a prospective, because a prospective is, okay, it's, as I said, it's less prone to a lot of things. So if you're very sure that you're going to have enough participants, then definitely favors a prospective. And if you want to decrease the chance for bias, it favors prospective, because in retrospective, there are a lot of things that you account for, given that you are not the one who recorded the data. So there are a lot of things that you might be modifying just to suit your purpose, and then you end up having a lot of bias. What could favor observational studies? If your research question is not about treatment or is not about intervention, if it will be unethical to randomize participants, because there are sometimes whatever intervention you're doing probably is very unethical to, I'll give an example. It's like you have a certain drug which works best, and you then are trying to randomize people to get the drug and the other people not to have the drug. So basically, that's kind of an ethical thing that you don't want to do. So that's supposed, like, it gives you to go into an observational study. Likewise, as we said, interventional studies require a lot of resources. So if no resources for you, you definitely need to do an observational study. What favors experimental studies? If it involves a treatment change. If you want to change and say, okay, we have been using ketamine for procedural sedations, probably I now want to change to a certain sort of drug, maybe to fentanyl. Now, given that there's a treatment change that you want to do, definitely you want to do an interventional study so that you could clearly have these groups, do your intervention, and then come up with results like this is what was done and this was the results based on the two groups. If you have enough time, you have enough money, you have enough personnel, which as a resident, I'm not saying that you don't have, but I know you don't have this time, money, and personnel to do an observation experimental study as a resident, because you only have a limited time. With money, probably you might have money. Let me not put that, but time and personnel you'll not have. So the key take-home points, what we have been looking at, to summarize again, just to bring things into context. We first began as, what is a study design? A study design is the approach, the strategy that you use to answer your research question. So whatever research question you have, it guides you to what study design you need to do to give you the results or the answers that you want. We looked into several concepts: prospective, retrospective, the advantage and disadvantage. And then we went to quantitative and qualitative research. In quantitative, we had observational and experimental. In observational, we had descriptive and analytical, and we saw what each of these could mean. In experimental, we saw what aspects of what things are preferred in an experimental study to make sure that whatever results that you have in the end will be, you can justify them. And then in the end, we looked at a component that is diagnostic studies. So diagnostic studies are also very important, since much of our practice that we do, we are always trying to see what best could I do or use in my low limited resource, but it could fully function in comparison to something that is standard. And again, as I said, the index test could be an investigation, it could be a clinical finding, it could be a score, it could be physician's judgment that accounts for that index test, which you are trying to see how best it performs in relation to the gold standard. So that if you do not have a gold standard, could I use this as a substitute and still give me some results that I want? So those are the things that we've been discussing. And finally, one of the things that you need to understand, we always have the evidence hierarchy. with whatever sort of study design that you're doing or you're going to incorporate, there's always a certain level of evidence that you should always also consider, or even when you're reading or dealing with research. So we always talk of quality of evidence and validity. Now, with this triangle that is here, the more that is the ones that are on the lower part, let's begin with an expert opinion. Expert opinion is whereby we'll be on a clinical shift, we'll be discussing a certain thing. Now, based maybe on experience, based on the repetition of that particular characteristic, so it's a presentation. Sometimes then you'll have an expert's opinion saying, like, when you have this patient coming in with this, there are chances that it's this. No studies that are really being done on that, but just that it's because it's something that happens repetitively, it presents the same, one might come up with an expert opinion. So this is a very low evidence in terms of research. Then from there, you might have case studies. Case studies, or you might have case reports or case series. Now, this brings a bit of bigger evidence or higher quality of evidence in comparison to expert opinion, because there's some sort of analysis or some sort of evidence that is available with case reports and case series. And then from there, you go to observational study. Now, observational, we have the prospective. It could be in observational where you can do prospective or retrospective. Prospective are more higher evidence. The quality of evidence with prospective is higher compared to the retrospective. Then you now go to the experimental, which is randomized control. And then at top, you have systematic reviews, meta-analysis, and clinical guidelines. So this is very important to understand the level of evidence, because it also helps you when you're making conclusions of whatever research that you're doing or whatever study that you're doing, or sometimes even if you're trying to develop something from a certain concept or thing that you have read. If you are looking at an expert opinion and you're trying to firmly stand on that, probably you might not be very right, given the level of evidence in research is very low. But if you're standing on a randomized controlled trial evidence, then someone will be like, okay, this could be, because we know the robustness of what happens with randomized control trials. So basically, what determines this is also the robustness of how these things are done to give the results. So this is also another important component that you always need to know when you are talking about study designs. And so to speak, this marks the end of our talk for today. But before fully winding and before welcoming any comments, I would like to welcome Bibi if there's anything to add, and then we'll welcome comments and questions and clarifications.
Excellent job, Humphrey. I think you covered everything very, very well. I think there are some terms that you have heard now that don't worry about them, but you will hear them again. But I did want to clarify a little bit because we really didn't ever define bias. And we're not talking about, the reason we talk about bias is because it's a kind of a systematic error that creeps into a study, usually because of the way you have set up the methods. And so for example, when you do a randomized study, you have patients that basically blinded you cannot decide as the researcher who goes into which group. So there's no choice here. There's no subconscious thinking that this person is sicker, I wanted them in this group. This person is not sicker, I want them in this group. So the point is that we're not talking about trying to make a study better, but our own subconscious decisions can often get in the way. So bias is when you do anything that creates systematic error. Another example would be even in a prospective study, if you sample, but Okay, I don't know if you all lost me or I just lost all of you. Um,
Yeah, we lost you a
can
bit,
you
but
hear
then
me?
yeah, we can now hear you.
Okay. So the point is it's not favoritism per se. It's really that you did something that might cut out a certain group of patients accidentally. As I'm saying, is if you sample in the day, but you don't sample at night because you don't have enough research personnel, there's a potential for bias because we all know that the people that come in at night are different than the people that come in during the day into an emergency department. So that's the kind of thing we talk about is like, and it's much of it's accidental, but it can lead you to an invalid conclusion because you haven't put all the right people in the study, or you have allowed some knowledge that you have about which group someone's in to affect your assessment. So that's what bias is. And so if there's a lot of bias, it's not that you get the result by chance. You get the result because you made a systematic error, and that makes it less valid. When we talk about chance, we'll be talking later about significance testing. So bias and chance are not exactly the same thing. So just kind of keep that in mind. The only other thing I just wanted to say, I think you did a really good job on this. Sometimes people do get confused about whether something's an interventional study or not. If you ever run into that question, say to yourself, did the researcher assign the patient to that group, or did someone else in the clinical care, for example, assign that patient to a group? Or was it the circumstances of birth? If the researcher did not assign the patient to a group, then it's not an interventional study. So that's often considered shall we say, the gold standard definition, in case you ever get confused, because there will be interventions, but the researcher is not assigning them. And that's really all I have to say. I think really good job, Humphrey. I didn't need to be here.
Okay, thank you very much. So for the remaining few minutes, let's say 8 minutes, we'll welcome any resident that would have a question or a clarification. So you can either unmute and speak, or you could just write it on the chat. I could also see if there's any questions or clarifications. Likewise, this session has been recorded. So we're also going to make a link for it, and we're going to upload it in the YouTube channel. If someone wants to go back and listen to it again, it will definitely be available.
Hello.
Yes, you're welcome.
Yes, thank you, Dr. Humphrey, for the nice presentation. I was asking, is there a required number of sample required for each study?
Okay, thank you, Doreen, for the question. So I'll just say again the question that Doreen has asked. Is there a required number of sample that is required for a certain particular design? Was that the question that you asked?
Yes.
Okay, so to answer that, which okay, again is not a part of this talk today, there's a part where you're gonna do sampling strategy and sample size, but there is not a fixed sample or a fixed number that is required for a certain type of study design. What is going to guide your sample size? There are factors that guides your sample size, and there are ways that you do sample size calculation to give you what number of study participants that you need that will be sufficient for you or will power you to conclude whatever results that you're saying. So the answer is we do not have a fixed number for these study designs, but there are things or factors that guide you into having a certain sample so that it powers you to say, my results are this, and I'm sure because I was powered by my sample to say this.
Okay, thank you.
Hussein, you're on mute.
Okay, so Henry was asking if, okay, my dissertation question is on observational study. Do we do descriptive only, analytical, or both? Again, so the decision of whether we're going to be doing a descriptive study, an analytical study, or both description with analytical is not a fixed, it's not a fixed answer. Like it should always be this. Again, whatever research question you design, it guides you just do a descriptive or do an analytical. But for your dissertation cases, which is now okay, which is what the university recommends, you should always do an observational study that is analytical, which will definitely have some description part of social demographic characteristics and the like, and then you'll have an analytical. So whatever research question you're going to be developing, in the end, there should always be an analytical component that you're going to be doing. But I do not want to say this is, you should start from the analytical and then go to the research question. What I want to say, your research question guides you to the type of study. Though we can always modify a research question in order to have the component of analytical. Because there are times we'll develop a research question and the objectives will just be, from what we develop, I'll tell you this is more of description. So we can modify that to add the analytical component. So that should not worry. But the recommendations from the university, there should always be an analytical component within your study. If you're doing a descriptive, you should have a very valid reason as to why you have done a descriptive. It's not that they are prohibited or limited, but then you will definitely have to have good justifications as to why you just did a descriptive study. Okay, thank you very much. Thank you all for attending our today's session, and thank you, Bibi, for joining us in our session. Having said so, having said so, I think we wind up our session now. And as I said, I've recorded the session. After sometimes we'll upload it in the YouTube channel. You can always go back to listen. You can always ask me whenever we meet of a concept that probably you didn't understand and you could not ask in the chat. That's also fine. But saying so, I'd like to wish you a good evening and I'd like to wish Bibi a good morning.
Asante.